Good afternoon, everyone. Can you guys hear me okay?
Sure can.
Awesome. All right, so we're going to spend the next about 15 minutes or so towing the line or looking at linezolid adverse effects and management. So next slide, please. I did want to start with a brief overview of linezolid. We use this very commonly in practice, whether that is for outpatient infectious diseases that we're commonly treating, such as cellulitis, to very severe infections, such as bloodstream infections with associated endocarditis that we see more commonly on the inpatient side. So just a reminder of the mechanism of action of linezolid. It's a protein synthesis inhibitor and binds to the 50S ribosome that breaks down the translation and then ultimately kills the bacteria. It is a weak MAOI, so that's something important to keep in mind as we go through adverse effects. Has excellent bioavailability at 100%. The IV is equal to oral in terms of that and dosing. It has excellent tissue penetration everywhere from pulmonary, skin and soft tissue, urine, bone, and CSF. So it gets to places in the body very well. And then I have a few things, and these are straight from the package insert, but we're going to go through them a little bit more in depth. But if you look at the package insert, the dose is 600 milligrams Q12 with no renal dose adjustment recommended, and they do state a duration limit of 28 days. So we're going to talk about a bit more about that, but just keep that in the back of your mind too. Its spectrum of activity is very broad in terms of gram-positive coverage, MSSA, MRSA, strep species, enterococcal species, including VRE. It has some odd spectrum when we think about non-tuberculosis mycobacterium tuberculosis, nocardia, listeria, corynebacterium, and then more recently, its use in antitoxin effects with staph, strep, and clostridium have been explored, especially in necrotizing skin and soft tissue infections. Next slide, please. But let's look at this package insert versus a real world experience. So package insert is the point here. I mentioned all of these things already, but also there is listed a category X interaction with serotonergic agents due to the risk for serotonin syndrome. But I want to counterpoint this with a bit of real world experience. One, is there really a standard dose of any antimicrobial available? No, we'll go through that a bit more. No renal dose adjustments are needed per the package insert, but renal impairment does increase exposure of linezolid. We'll dive into that a bit more. It says the duration limit is 28 days, but we use linezolid for TB and NTM treatment, which that treatment can be 6 months or longer. And then I'm not even going to say my counterpoint for the serotonin syndrome. I just included an eye rolling emoji, but we will talk about that more in depth too. So next slide. So there's a ton of intra-individual variability on PK and PD with linezolid. It is not a one size fits all, despite that very labeled 600 Q12 dosing. So a few things can increase exposure with linezolid, and that's renal impairment, specifically acute kidney injury, or we see this a lot in our end-stage renal disease patients, particularly on intermittent hemodialysis, elderly patients, patients with low body weight. Critical illness is actually one that can increase or decrease exposure. So it really just depends on what's going on with the patient. And same with drug-drug interactions. Some things can increase exposure, some things decrease exposure. Things that are unique to decreasing exposure are obesity, burn patients, and cystic fibrosis, just due to the way that the antibiotic is distributed. Next slide, please. So let's dive a little bit into our adverse effects. So the following that are listed on the slide here are dose and duration dependent. So these are things like myelosuppression, which comprises anemia, leukopenia, pancytopenia, or thrombocytopenia. The two neuropathies that we see are peripheral neuropathy or optic neuritis, and then lactic acidosis as well. If we look at the next slide, I've broken these down. Actually, I want to go into the mechanism of action behind these adverse effects. So I'll start with This is really not super well understood, but if we look back at the way that this antibiotic works, it is a protein synthesis inhibitor, and it binds to the 50S ribosome. It works so well that it actually combined to our human ribosomes as well. So the mechanism behind all of those adverse effects I just listed are possible mitochondrial toxicity or disruption of mitochondrial protein synthesis, really by binding to that same piece in human cells. And if we think about the different areas of the body that are dependent upon oxidative metabolism that occurs in the mitochondria, that's our retina, optic nerve, brain, skeletal muscle, kidney tissues, which may explain a bit why these specific adverse effects can occur in linezolid. And there's also a thought about genetic susceptibility to linezolid toxicity. So this is very similar to the genetic susceptibility that we see in aminoglycosides and hearing loss. It's the same piece with linezolid. So we don't know a ton about that from the clinical perspective yet, but from the basic sciences perspective, there may be certain patients that have a genetic susceptibility based on different genetic makeup. So next slide is where I will go into how common are these adverse effects. So I did throw serotonin syndrome in here because I really want to highlight a couple points with it too. But I'm going to go through each one of these adverse effects we just mentioned, the incidence, the onset, and then unique risk factors that are associated with them. So myelosuppression can occur in up to 30% of patients. In the original trials that looked at linezolid, they saw only a 3% incidence, but I think anybody that's used this in clinical practice could say it's probably more up to the 30% mark. And the onset of this is typically about after 14 days of therapy, but it has been reported as early as 7 to 10 days, particularly when a few different unique risk factors are present, such as baseline platelets less than 200, severe kidney or liver impairment, or concurrent meds with the same risk of myelosuppression. I also want to point out that all of these outside of serotonin syndrome have the risk factor of prolonged use over 28 days and a trough serum concentration of greater than 2. Peripheral neuropathy and optic neuritis, I do want to say this is more common in TB treatment, probably because we're using this for much longer durations of therapy. But you can see here the incidence is a very wide range, with most of those 50 and 30% respectively being in our TB population. Onset here is greater than 28 days, and there really haven't been a lot of unique risk factors associated with these two. Lactic acidosis is actually a little bit more common than maybe what we've thought before, and this is about 7% reported in the literature. Onset is most common after about 28 days of therapy, but can occur sooner. And the unique risk factor with this is age over 60. But I also want to point out serotonin syndrome. So I think this one gets highlighted a ton, and it makes folks shy away from linezolid use. But when we actually look at the incidence of serotonin syndrome, when it's co-administered with other serotonergic agents, it's actually less than 1% and maybe at highest up to 3%, which is lower than almost everything else, even including optic neuritis. So I think that this is the one that gets the most attention, but does not deserve it based on the incidence that we see, especially in these post-marketing studies. The onset can be day 1 of therapy to 20 days of therapy, and the median that's about 4 days. And of course, the risk factor here are other serotonergic meds as well. So looking at the next slide, I just break this down just a bit into symptoms and laboratory abnormalities. For the sake of time, I won't go through these in depth, but they're here on the slide for your reference. I think that a couple things I do want to point out is that myelosuppression may be asymptomatic. So that's another reason why we do want to check our labs frequently in patients that are on linezolid, particularly long term. The lab abnormalities are pretty self-explanatory there. Optic neuritis, I do want to point out, I've never personally seen that in a patient, but they will report decreased visual acuity, decreased colored vision, and sensation and brightness. But optic neuritis and peripheral neuropathy are really self-reported side effects as a serotonin syndrome. There's really not a lab marker for those. Whereas lactic acidosis can be a bit misleading. You know, this can just start as nausea, vomiting, but we really need to get some additional labs that we don't typically collect on, especially on the outpatient side, to assess for this, such as bicarb levels, lactate, assessing the anion gap, and then seeing if the patient is acidotic. Next slide, please. The good thing is that most of these are reversible outside of peripheral neuropathy. So that one is actually not always reversible. That one the patient may be stuck with for life, even after discontinuation of linezolid. And optic neuritis may not always fully reverse. You may see just some slight improvement, but it usually does improve. Most of these do recover within 2 weeks. Serotonin syndrome is the quickest to recover. And generally, our management is to stop linezolid. I think some of these, particularly myelosuppression, there's a few different ways we could manage that, which I think we might get into with some cases today. But in general, we will stop the agent, and you'll see these reverse, except for the neuropathies. Moving on to our next slide. So how do we toe the line, right? How do we balance a risk versus benefit? So how do we ensure that we can get a clinical and microbiologic cure while decreasing our risk of toxicities? And if we look at the next slide here, I think that this is where we can explore the role of therapeutic drug monitoring, or as I will reference this as TDM moving forward. Our next slide goes back to that balance or seesaw. And this text is kind of small, so I'll read this out to you guys. For the risk side, so troughs of over 8 to 10 have been associated with increased thrombocytopenia, but conversely, optic neuritis and peripheral neuropathy have been associated with therapeutic troughs as well. So our TDM doesn't always predict toxicity, but it can be helpful for us. And of course, while we're monitoring TDM, we want to make sure that we're also achieving clinical efficacy. So troughs of 2 to 8 are associated with increased likelihood of clinical cure. There's actually a recent study that just came out that showed an increased mortality and lower clinical cure rate associated with supratherapeutic troughs. So you think, oh, the more the better. Actually, that's probably not the case. So not only with supratherapeutic troughs are we putting our patients at higher risk for toxicity, we're doing them no clinical benefit either, by potentially increasing mortality and lowering clinical cure. Moving to the next slide, we'll see our linezolid target. So linezolid is really an AUC to MIC drug. We want our free trough concentrations above the MIC about 85 to 100%, and our target troughs are 2 to 8 generally. The recommendation is to obtain a steady state trough after about 4 to 5 doses and obtain within 60 minutes prior to that dose. If it's drawn too early, so with it, say you draw it 8 hours before the next dose or 7 hours before the next dose, it will need to be repeated. So really want to get it within that hour prior to the dose, at most probably about 2 hours. Moving to our next slide. Is linezolid TDM for everyone? So I would say, given the information that we have now, and I'll go into that a little bit more in depth, it's not for every single patient, but I do think there are plenty of patients that can benefit from TDM. So critically ill patients, elderly patients, patients with renal insufficiency, augmented renal clearance, or a change in renal function while they're on linezolid. So patients that originally had, normal renal function, but then developed an AKI while on therapy, they are at risk for increased linezolid exposure. Extremes of body weight, obese and low body weight, patients with liver cirrhosis, our prolonged therapy of over 2 weeks, any drug-drug interaction. So sometimes we will use linezolid in the presence of rifampin, whether we're treating a prosthetic joint infection with a staph species, or tuberculosis. We might be using it with rifampin, which can lower the exposure of linezolid. And there's other drugs that also can lower or increase exposure of linezolid. In the setting of adverse events, so this is where most of the TDM has been done, and I'll show one study for that, but this can help mitigate some of those adverse events. So a pathogen with an elevated MIC greater than 2. So this would be if you have a staph infection with an MIC of 2 to 4, we would recommend a linezolid TDM for those folks. And then after a TDM, guided dose change is generally recommended as well. Moving to the next slide. I do want to go through one study looking at TDM for efficacy, and then I'll go through another study looking at TDM for safety. So this was just published, I think, back in March, and it's early adequate linezolid concentrations in clinical outcomes and confirmed gram-positive infections, looking at TDM specifically. So to briefly summarize this study, the patient population was confirmed gram-positive infections. Most of these were Staph aureus or Enterococcus who received linezolid TDM. This was a pretty even split between intra-abdominal infections, SSTIs, and respiratory infections. And they had 400 patients, all who were started on that standard 600 Q12 dose. So this was a retrospective study. They did get a steady state linezolid concentration right before that 5th dose of therapy, and they considered therapeutic trough to be between 2 and 8. So the results that I thought were most compelling out of this is that only a third of patients achieved a therapeutic trough on standard dosing, and it was pretty even split between the other 2/3 between supra and subtherapeutic. But achieving a therapeutic trough at steady state significantly increased the likelihood of clinical cure. So this is the study that found that if they had a steady state trough of 2 to 8, they had a statistically significant increased likelihood of clinical cure. And it's also the same study that saw that with a supratherapeutic trough at steady state, they had an increased mortality rate and an increased rate of treatment failure. Looking at our next slide here. So this goes into TDM for mitigating adverse events. So this was the Limit 1 trial, which looked at 622 patients receiving linezolid for greater than 5 days. So this is one that actually didn't have everyone get TDM, but they just had a subset of patients who did. And they went back and looked at this through a retrospective study and really assessed steady state linezolid concentrations, once again, the same therapeutic range. And what they found was toxicity was associated with a higher serum creatinine, lower baseline platelet, or duration over 14 days, which is very much in line with what was previously presented and what we already know. They only had TDM performed in 23% of these patients, and this actually was most likely to be performed in the above patients, so those patients who were at higher risk of toxicity, or if the patients developed toxicity on therapy. So it wasn't a standard everybody got TDM, it was pretty much case by case. But appropriate dose adjustments significantly reduced the odds of ongoing toxicity or developing toxicity if it was obtained prior to a toxicity developing. So we have published literature showing that while if we achieve a therapeutic concentration at steady state, we have better outcomes and we could mitigate adverse events. We go into our next slide here. I did want to bring this up because I actually didn't know about this until I was doing this presentation. But there actually is a tool online, and this is published in the published literature, and I can send out the link to this in the chat, or if Chandria, I could send it to you and you could send it out to the participants. But it's actually a predictive score for selecting patients who are candidates for linezolid TDM. And you can see here, you can go through the age, if they're greater than or less than 65 years old, whatever their baseline GFR is, well, currently what their baseline GFR is, and their linezolid daily dose per body weight. So whatever they're receiving mg per kg, if they're admitted to the ICU, and if they have the presence of liver cirrhosis. And when you push all this in and hit complete, it actually gives you some like statistics of this patient is X% likely to be therapeutic, subtherapeutic. But a group out of Australia put this together, and it's actually, I think, one of the same groups that did one of the studies that I just mentioned. So I thought it was pretty interesting. I haven't tried it out in clinical practice, but I thought it would be a good tool to share with the group. If we go to our next slide, some TDM considerations. So the formulations do have to be considered. So the tablets are unscored. So we do recommend that patients, when they cut those in half, they use a pill cutter to make sure that they're actually getting an even split. There's a suspension, but it is quite pricey. There are different IV formulations, of course, but that's so for the inpatient setting. There's also a variety of labs throughout the country that offer linezolid assays. Here at WV Medicine, we're most familiar with Atlantic Diagnostics Laboratories, but the other ones can perform this as well. And of course, the rate limiting step is turnaround time. We found this can be between 2 and 13 days. So really, if you're getting past that 2 days, you're really kind of running out of that room to make it beneficial for your patient to actually make a dose change. If we go to the next slide, I think I'd be amiss if I didn't talk about linezolid's cousin, tadazolid. So there's actually a really nice review paper looking at tadazolid, linezolid, and the adverse effects associated with it. And there is a thought that tadazolid has increased safety, that it has a lower risk of myelosuppression. The real world use that we do have that's been published suggests very low risk of neuropathies or lactic acidosis. But I would like to point out that we do not have the breadth of real world data that we do versus linezolid. So if we use tadazolid more, we might see more adverse effects. But what we do have is we do know it's safer. However, it is very expensive and it's about 5 times the price of linezolid. So the AWP for the 600 milligram tablet, that is the average wholesale price for linezolid, you can see is $183 versus the 200 milligram tadazolid tablet at almost $600. So just wanted to put that out there. But if we go to our next slide, I will sum this all up. And I'll say linezolid toxicities are real and some are potentially life-threatening. Linezolid TDM may play a role in mitigating adverse effects and ensuring clinical efficacy. However, I do believe more data are needed to determine optimal linezolid dosing strategies and TDM recommendations to ensure optimal efficacy while mitigating toxicity risks. Particularly when we use these for prolonged treatment of infections like our cardiac joint infections or for uncommon pathogens. So I mentioned the efficacy data for gram-positive infections, but that was mostly staph. So we don't have a ton of data in the efficacy realm for TB and TM or nocardia. And the next slide is just my references. But with that, I will conclude.